Okay, my screen is still visible, right?
Yeah.
Okay, so we can start now. Okay, this is the end of year exam which we did, specifically the MCQs. So we'll go and analyze each question as best as we can. So starting with number one, which statement is incorrect? Okay. Paracetamol has weak or no anti-inflammatory effects. Selective cyclooxygenase 2 inhibitors do not cause gastrointestinal ulcers. Ketorolac is used as an analgesic for less than a week, and indomethacin causes headache. Ibuprofen prolongs bleeding time. So this question is for the topic of paraminophenols, like the analgesics. So you can go and look at it. You can go and search for the answer from directly from the notes. So the question was asking about paracetamol. Okay, choice A is talking about paracetamol having weak or no anti-inflammatory effects. So, okay, paracetamol, okay, it's an acetaminophen. It is an active metabolite of phenacetin. So classification is a para-aminophenol derivative, and it has weak anti-inflammatory action. So because of this, some texts don't classify it as an NSAID. So yeah, it's not technically an NSAID because it has little to no anti-inflammatory action, but it's just placed under NSAIDs, like just for, I think, for formality. So here, choice A is true. Paracetamol has weak or no anti-inflammatory effects. So for choice B, selective cyclooxygenase 2 inhibitors do not cause gastrointestinal ulcers. So you can get the answer to this. Okay, we can get more information about this on slide 55.
Are you showing another kind of slides because you are still on the slides with questions?
Oh, sorry. Okay, I thought like when I change tabs, also you guys are seeing me my screen change tabs. Okay, let me.
You have to share your entire screen for that to work.
Oh, okay. Let me try doing that again. Okay, I'll redo the question over again so that it's more comprehensive. Okay, you can see my screen.
Yes, you can see it.
Okay.
Yes.
Now, when I move to another tab like here, is my screen?
Yeah, now we can see the slideshow.
Okay. Sorry about that. Mishap in the beginning. So, what I was saying for choice one, the choice A was saying paracetamol has weak or no anti-inflammatory effect. Is that correct, or is that true or false? So here, we have been told that paracetamol has weak anti-inflammatory action, and because of this, some texts do not classify it as an NSAID. So I was saying paracetamol is not a true NSAID. It's just placed under that category for formality. It's just a special sort of NSAID, but it's not a real true NSAID. It's an acetaminophen. Okay, I know that the other name for paracetamol is, I think, acetaminophen, yes. It's an active metabolite of phenacetin, and it's under the classification of para-aminophenol derivatives. So just for the sake of exam scenario, you can just read more about paracetamol in case they might want to ask more another question regarding paracetamol. So the mechanism of action of paracetamol is that it inhibits cyclooxygenase in environments that are low in peroxide, such as the hypothalamus. So it's a COX inhibitor. Its sites of inflammation have increased WBCs that produce peroxides. Pharmacokinetics, so it's given orally. I think, yeah, it's quite common. I think mara moja is paracetamol. I'm not sure, but I think, yeah, Panadol, mara moja, they have paracetamol as the active ingredient, so they're taken orally and they're rapidly absorbed. They can also be given rectally or IV infusion. So rectally, maybe, I don't know if you can give paracetamol through suppositories, but okay. Turns out they can be given rectally. They're widely distributed in most body fluids. So if they're widely distributed, this could mean that it has a, what can I say, a large volume of distribution. Yeah. So plasma protein binding is 20 to 50%. So when a drug is highly protein bound, less of it is taken up into tissues. So its effect is, the effect of that drug is lowered. So let's say if a drug is like 99% protein bound, let's say to albumin, it means most of it is being transported and less of it is like actually being diffused or transported into the, like into the cells. So its action is quite low, and therefore you need to increase the dosage to realize the effect of that drug. So for paracetamol, as you can see, it's not that greatly protein bound, just 20 to 50% is protein bound, meaning the actions of paracetamol are well realized. Yeah, so there's like no need to overdose or take a large dosage of paracetamol. Half-life, 2 to 4 hours. In the exams, they like asking about these half-lives a lot, like especially in the MCQs. But I think we once told in a lecture that for the half-lives, you just need to, like, I think, capture the drugs which have those very, very outstanding half-lives. Like some drugs have half-lives that are like days. I think some malarial drugs have half-lives that are like, I don't know, more than 24 hours, So these other drugs that are like less than, like a few hours long, they are quite normal, or the ones that are really short, like a few minutes. Also, those ones you should get like you should capture the drugs that have very long half-lives or very short half-lives. The ones that are like a few hours long are not that important, but you could try your best to like memorize them. So for paracetamol, half-life is 2 to 4 hours, and it's prolonged to 4 to 8 hours with toxic doses. So the half-life can double in toxic doses. Paracetamol pharmacokinetic, okay, it metabolized in the liver. If it's metabolized in the liver, it means it undergoes fast pass effect, which means that its bioavailability in the blood is not 100%. Yeah, most metabolites are conjugated. A small amount is hydroxylated to an acetylbenzoquinine amine. It reacts with sulfhydryl groups in glutathione. When glutathione is depleted, into brackets overdose, it binds to hepatocytes and renal tubular cells. Okay. Under pharmacokinetics, we have talked about like drug metabolism, and there are two phases of drug metabolism. There are phase 1 reactions and phase 2 reactions. Does anyone know like the examples of phase 1 reactions? I think it's a common question, especially in SAQ. So Does anyone would anyone like to mention any phase 1 reactions and their significance? Okay. I don't know.
can mention
Yes.
the oxidation reactions, and mainly for making the drugs more polar for, I think, excretion.
Yeah, for excretion or elimination. So there's
Yeah.
oxidation. I think there's a formula I had. There's a formula I had for remembering. I don't know. Okay. So there's reduction, oxidation, I think hydration as well. Yeah, and the purpose is to make the drug more polar for excretion. Okay. So paracetamol is excreted in the urine. Okay, that's a key point to note, because some drugs are not excreted in the urine, others are just excreted in feces primarily. Okay, and paracetamol adverse effects, we have skin rashes, pancytopenia, though it's rare, renal tubular acidosis, hypoglycemic coma. So I think this is a very like a high yield question. These ones for adverse effects, they can tell you all the following are adverse effects of paracetamol except, or which one is an adverse effect. So skin rashes is, I think, very high yield, and renal tubular acidosis. Actually, I think many drugs cause acidosis, especially metabolic acidosis. So yeah, this one is also a key point to note. Hypoglycemic coma, those three. Pancytopenia is there, but it's rare, so I don't think it's a very common thing, a very important thing to write, because it's very rare. So skin rashes, renal tubular acidosis, and hypoglycemic coma are some adverse effects of paracetamol. Paracetamol can also be hepatotoxic, but it has an antidote, which is this, N-acetylcysteine, or NAC. I think can be shortened to NAC. It should be given in less than 12 to 36 hours after the paracetamol overdose. So yeah, so this hepatotoxicity being an adverse effect of paracetamol is very high yield, because not only can you be asked about the adverse effect of paracetamol, but from this, like, not only can you be asked about hepatotoxicity being an adverse effect of paracetamol, but also you can be asked for the antidote. So yeah, the antidote is this N-acetylcysteine. And I think also this oral methionine. Yeah. I think this also is in the topic for poisonings or something. Yeah. Also, another thing to note, paracetamol has no aspirin-like effects on the respiratory system, cardiovascular system, on pH, platelets, uric acid levels, and GIT bleeding. So this means that since paracetamol is sort of like an NSAID, so it sort of acts like aspirin, but it acts like aspirin in every system, almost every system, except in the RS, CVS, on pH, platelets. Okay. I don't know. I don't remember. I don't know if NSAIDs promote platelet aggregation. Just check. Someone can correct me if I'm wrong, by the way. Anyone can correct me if I'm wrong.
I think some do.
Oh, so I just checked. NSAIDs, they usually inhibit platelet aggregation. Yeah. So paracetamol does not inhibit paracetamol, since it does not act like aspirin in terms of platelet aggregation. It does not inhibit platelet aggregation, because NSAIDs usually inhibit platelet aggregation. NSAIDs also may cause GIT bleeding, like in PUD, in peptic ulcer disease and stuff. So most NSAIDs usually cause GIT bleeding, but paracetamol doesn't. So I think those are key points to note: platelets aggregation and GIT bleeding. Yeah. So going back to the question, at least you have gone through much about paracetamol in regards to choice A. So choice B was saying selective COX-2 inhibitors do not cause gastrointestinal ulcers. So they actually do. And the evidence is in slide 55. Let me just like jump there. Okay, COX-2 selective inhibitors. They may also be referred to as COX-SIBs. COX-1 isoenzyme. Okay, it's constitutively active for housekeeping. It's found in the GIT, kidneys, and platelets. So by housekeeping, it means like it keeps the systems of the body intact and functioning. COX-2 isoenzyme induces sites of inflammation. So for these cyclooxygenase enzymes, they are talked about in more detail in second year notes. So I really don't want to go into deep discussion about them right now, because we might stay too long on this question. So just know like the COX enzymes are spoken in more detail in second year. So they have no impact on platelet aggregation at usual doses, mediated by thromboxane produced by the COX-1 isoenzymes. So they inhibit COX-2 mediated prostacyclin synthesis in the vascular endothelium. Therefore, COX-2 inhibitors do not offer the cardioprotective effects of non-selective NSAIDs. So here, this is where the key point we need to note is COX-2 inhibitors do not offer cardioprotective effects. They do not offer like the protective effects of non-selective NSAIDs. So in the stomach, I think there's usually a protective mechanism to the COX enzyme, to the COX compounds. So once the NSAIDs inhibit those COX compounds, they reduce the protective mechanisms involved in the stomach, and hence like they cause now the increase in acid production that may cause ulcers. They increase sensitivity to acid that causes ulcers. So here in choice B, selective cyclooxygenase inhibitors do not cause gastrointestinal ulcers. That's very false, because if the COX enzymes are inhibited, there'll be GIT bleeding and ulcers as a result, because there's no protective mechanism in the stomach. So choice C, ketorolac is used as an analgesic for less than a week. So here, again, this is directly from the notes. It's in slide 35. So let me just go there. I hope you noticed that that question was just lifted from this PDF, the way it is. So ketorolac is administered orally, intravenous. So ketorolac, it's administered orally, intravenously, intramuscularly, and tropically, and also intranasally. So it has various routes of administration. So yeah. Toxic effects in the blood. It inhibits platelet aggregation. In the CNS, it causes somnolence, which is sleepiness, dizziness, and headache in 17% of cases. JT, nausea, dyspepsia, I think, which is like, I think dyspepsia is indigestion or something. Yeah, and ulcers. At the site of injection, it causes pain. So for the use, it's used only for short-term analgesia, acute pain. So it's not used for long-term. It's not used for more than 5 days due to high risk of adverse effects. It's a potent analgesic, so it's used in severe pain / moderate or poor anti-inflammatory. It has moderate or poor anti-inflammatory effects. So I think because it's a really potent analgesic, it's not used for a really long time. So that's something we need to note about ketorolac. It's a very potent analgesic. Therefore, it's not used for a long time. It's used only for short term, not more than 5 days. And also, it's not used for a long time. It's very, it has a high risk of adverse effect. Yeah. Okay. It's used for post-operative pain, inflammatory eye conditions. Yeah, so this is the reason why it's given, I think, I don't know if it's given in droplets. Yeah, or topical. It's given topically for the eye. So yeah, because of the inflammatory eye conditions. Postoperative pain, so then again, this is severe pain, like maybe someone has gone through like let's say amputation or something. So that's severe pain, which requires ketorolac to be given. Yeah, so because ketorolac is very potent, it's used for those extreme cases of pain. So ketorolac and opioids are used in opioid dose reduced by, okay, ketorolac can also be used with opioids. Remember, opioids are analgesic, so the combination will reduce pain. Ketorolac and an opioid will reduce pain. So, nice, just a repetition. Yeah. So here the question was saying, ketorolac is used as an analgesic for less than a week. So that's true because it's a very potent analgesic. It cannot be used for a really long time. So it's not used for more than 5 days. So C is true. So choice D, indomethacin causes headache. So we can go and fact check that in the same PDF, slide 12 to 17. Let's check. Let me just read all of indomethacin. So first thing we need to note about indomethacin is under the class of indole acetic acids. There are only given 2 examples, indomethacin and sulindac. So indomethacin's mechanism of action is a potent non-selective COX inhibitor. Okay, so it may inhibit phospholipase A and C, reduce neutrophil migration, and decrease T cell and B cell proliferation. So I think these all are attributed to the functions of COX. Again, you need to go back to second year work and read like the notes about cyclooxygenase, and icosanoids, and the other icosanoids like leukotrienes and stuff, to get more context of the relation of NSAIDs and COX and COX inhibitors and all that. So yeah. So pharmacokinetics of indomethacin, it's given orally. It's an NSAID, so it's given orally. I think most NSAIDs are given orally. Ophthalmic preparation, I think those are like an eye drops or something. Oral rinse, so I think that's mouthwash. Intravenously, and epidural injections. Epidural is like, I think on the skin. Yeah. And most of these drugs that are given subcutaneously, usually a good number of them usually have pain at the site of injection. Yeah. Peak concentrations are in 1 to 2 hours. The concentration of the drug in the CSF is low, so I'm guessing it has low CNS penetration. And the concentration of the drug in synovial fluid is equal to that in plasma within 5 hours of administration. Okay. Indomethacin undergoes enterohepatic cycling, and I don't know what that means. Let me check. So according to Google, it says enterohepatic cycling occurs by biliary excretion and intestinal reabsorption of a solute, sometimes with hepatic conjugation and intestinal deconjugation. So I think like some drugs like they rotate between the intestine and the liver, being conjugated and deconjugated again. It's like a cycle. I think that's why it's called enterohepatic, because entero is the intestines and hepatic is the liver. So yeah, so half-life is variable. That's so we cannot give like a specific number on the half-life because of the enterohepatic cycling. So I think that's something key to note, that indomethacin has enterohepatic cycling and undergoes enterohepatic cycling. So, but the average they've given is like 2.5 hours. So, yeah. Adverse effects, 35 to 50% of patients receiving indomethacin experience adverse effects. So that's a really large number, because almost half of people taking indomethacin experience adverse effects. So that's really, it's very important that we take into consideration that indomethacin has almost a 50% chance of someone getting adverse effects when administered this drug. So some of the adverse effects in the GI are common and can be fatal. Elderly patients are at greater risk. Okay. There's acute pancreatitis, hepatitis again. Okay, in addition to paracetamol, we've also noticed that indomethacin also has like adverse effects related to the liver, hepatitis. So the most frequent CNS effect is severe frontal headache. This is the most frequent one, so the most common one. So yeah, it's ironic that an analgesic will cause a headache. So yeah, I guess that's something special about indomethacin. It causes severe frontal headache, which is kind of, like it's kind of ironic. So there's dizziness, mental confusion, seizures, severe depression, psychosis, hallucination, and suicide. I guess because of the pain and everything. So yeah, so one key thing to note is that indomethacin can cause seizures. That's a question that can come in the SAQs. So, and seizures, okay, what drug can you give to treat seizures? Does anyone know? Anticonvulsant drugs. You don't have to be specific whether they are for which type of seizures, whether general or localized.
Benzodiazepines.
Pardon?
Benzodiazepines.
Benzodiazepines. Okay. Any others?
Ethosuximide.
Okay. Okay. Sitakuwa nimeshika hiyo. Okay. You say the name is?
Ethosuximide. It's for absent seizures.
Absent seizures.
Yeah.
Okay. So for seizures, there are two types of seizures. There's focal seizures and generalized seizures. So for focal seizures, they affect just one side of the brain, and generalized is for both sides of the brain. So for focal, we have very many drugs under which treat like focal seizures. Good examples are phenytoin. By the way, phenytoin is a really special drug because it's mentioned many times in very many topics. So it's good that you really note phenytoin is a special type of drug. Phenytoin, valproic acid, topiramate, yeah, carbamazepine, and oxcarbazepine. Okay, one thing I like, which helps me remember some of these drugs, is they usually add prefixes to other drugs, or some drugs have like very similar pronunciation. Like here, there's a drug called carbamazepine, and also under the same category of drugs, there's another drug called oxcarbazepine. So if you're listing them, it's easy to remember. Yeah, it's like lorazepam, diazepam, like they end with pam, pam, pam. So there's a trend that makes it easier for someone to remember. So yeah, so that's just digressing a bit to remind ourselves anti-epileptic drugs. Okay, so this was under indomethacin, they cause seizures. So if indomethacin may cause seizures, you may give the patient anti-epileptic drugs such as phenytoin and the rest. So caution should be given to elderly patients. Epilepsy, because it can cause seizures. Psychiatric disorder, why? Because it causes psychosis. So yeah, we should also we can give indomethacin with maybe antipsychotic drug medication such as haloperidol, clozapine, olanzapine, and the others. Parkinson disease, yeah, because there are greater risk for the development of serious CNS adverse effects. So yeah, so we should know that indomethacin causes serious CNS adverse effects. Yeah, so yeah, that's something special about indomethacin. It's hematopoietic. It can cause neutropenia, thrombocytopenia, and aplastic anemia. So it's rare. So, but if it causes aplastic anemia, it will obviously cause neutropenia and thrombocytopenia as well. Yeah. So I think I've gone deep enough for indomethacin. That's the question. Causes headache, yeah. But I guess we've delved deep enough on indomethacin. Ibuprofen prolongs bleeding time. Yeah, I guess so. Slide 40. Okay, the answer to this is in slide 44. So ibuprofen. Okay, ibuprofen given orally, topical as a topical cream, gel, or intravenously. It has rapid absorption and the half-life is 2 hours. It's 99% bound to plasma proteins, meaning little of the drug is absorbed into the tissues, because most of it is being bound to the transport proteins instead of being diffused into the tissue. So meaning there's need to increase dosage or something, or to give a high dose so that the effect of the drug is realized on the patient. Accumulates in synovial fluid. I think indomethacin also accumulated in synovial fluid. Yeah, I think so too. So the synovial fluid thing is also something key to note. It crosses placenta, excreted as metabolites in urine. Yeah, so most of these NSAIDs are excreted in urine. I've not seen one which is excreted in feces so far. Toxicity causes epigastric pain, nausea, and heartburn. can cause thrombocytopenia, agranulocytosis, which is it's rare, and aplastic anemia. So I think I don't know which is rare, granulocytosis or aplastic anemia, but they are both possible adverse effects of ibuprofen. So yeah, notice how both ibuprofen and indomethacin have aplastic anemia and thrombocytopenia, I think. Yeah. Because it also causes a headache, same as indomethacin, and dizziness, same as indomethacin. Blurred vision, toxic amblyopia. So amblyopia is a lazy eye. So like an eye which it's not looking okay, it's one eye is looking straight, the other one's not looking straight, and the lazy eye also has blurred vision. So yeah, that's what amblyopia is. And also cause fluid retention and edema, aseptic meningitis, especially with patients with SLE. So I think we should avoid ibuprofen in patients with lupus. Okay, so it can cause PDA, patent ductus arteriosus, in preterms. That's in the fetus. Okay, can be used occasionally in pregnancy and breastfeeding. So here under PDA, I forgot to mention indomethacin is used to close the patent ductus arteriosus. Yeah. So yeah, sometimes when the fetus is born, there is need to keep the PDA open, maybe for some surgical intervention of some reason to treat some congenital heart anomalies. So there's reason to keep the PDA open. But now, usually it's unnatural to keep the PDA open, the ductus arteriosus open, because the body has mechanisms to close it before the child is born. So keeping it open is man-made intervention. So once you are done keeping the PDA open, the body now can't close it, because now, I don't know, like the time for the PDA to close has passed. So we need to close it now artificially, and we use drugs such as indomethacin to do that. And I think that was also a high yield question. I think I saw it somewhere. I just know indomethacin is used to close the PDA. Yeah. So ibuprofen in lower doses, less than 2,400 milligrams per day, causes analgesia. Notice how even 2,400 is, I think it's a very high concentration drug dose. It's because ibuprofen is 99% protein bound. Therefore, you need to give like a high dose for the drug effect to be realized on the body. So in high doses, causes anti-inflammatory effect. And you know why I'm saying it causes high doses? Because it's highly protein bound, 99% protein bound. Interaction with anticoagulants such as warfarin is uncommon. Antagonizes aspirin effect on platelets. So what was the effect of aspirin on platelets? Does anyone remember? What was I think we said it during this session. What was the effect on aspirin on platelets? Sarah, do you remember the effect of aspirin on platelets?
Yeah, it prevents platelet aggregation.
Yeah. It inhibits platelet. So aspirin inhibits platelet aggregation. So when we say ibuprofen inhibits the aspirin effect on platelets, we mean it inhibits the inhibition of platelet aggregation. Meaning it promotes platelet aggregation. Because aspirin inhibits platelet aggregation, ibuprofen antagonizes that, so it promotes platelet aggregation. Okay. I guess now I think we've covered that question enough. Okay, we can go to the next one. Which local anesthetic has the highest risk of cardiotoxicity? So this question, you can find it in the topic of local anesthetics.
I have a question.
Yes.
When you've said it antagonizes aspirin effect, so it reduces the effect of platelet, it promotes platelet aggregation.
Yes.
So how comes then we are saying that ibuprofen it prolongs bleeding time if it promotes platelet aggregation?
It promotes bleeding time.
Prolongs. That's in the question. It was one of the choices.
Okay. So I don't know how to do it. Okay, let me just check if ibuprofen actually prolongs bleeding time. Okay, so Google is saying the mechanism by which ibuprofen prolongs bleeding time is not established, but may relate to inhibition of platelet function through inhibition of prostaglandin synthesis. So I think it's just a fact that ibuprofen prolongs bleeding time, but it's not well established how it does so. But it may be because it relates to inhibition of platelet function through inhibition of prostaglandin synthesis. So let me just check. Let me just check what's the effect of aspirin so that I'm sure of the explanation. Okay, I better understand the explanation. Okay, so Google says aspirin reduces the ability of your platelets to stick together to form a clot. So that's aggregation. So aspirin inhibits platelet aggregation. So the notes are saying ibuprofen antagonizes the ability of platelets to aggregate. So it promotes platelet aggregation. So yeah, maybe ibuprofen promotes platelet aggregation, but somehow in another mechanism, it prolongs bleeding time. It's just that we are not sure how. So many things in science are like that. Like things happen, but we don't have a clear explanation of how they happen. So I guess that's how we need to. I think as long as we know ibuprofen prolongs bleeding time, that's okay. And also, if we know ibuprofen antagonizes aspirin effect, that's also okay. I think so.
Okay, thank you.
Okay. Okay, so which local anesthetic has the highest? Okay, by the way, I hope you guys have noticed how for question 1, the entire question just came from one PDF. So that's why I really insist on you guys, as you're going through the past papers, really make an effort to go back to the notes to, like to dig where the questions came from. It will really help. Okay, which local anesthetic has the highest risk of cardiotoxicity? So the answer here is bupivacaine. They are found in the topic of this topic for what? Anesthetics, local anesthetics. Okay. Yeah. So slide 26 can explain it. So bupivacaine adverse effects, more cardiotoxic because it dissociates much more slowly from the sodium channel. Yeah, the cardiotoxicity of bupivacaine is a very common question. By the way, one way you can tell whether a drug is local anesthetic. Okay, there's amide and under local anesthetics we have amide and esters. So for amide anesthetics, if the drug has two letter I's in them, like the bupivacaine has one I, another I. If it has two I's, it's an amide. It's an amide and LA. If it has only one A, like in cocaine, it is a ester. It is an ester LA. So that's just one thing I wanted to mention. Yeah, so moving quickly to the next question. True of Montelukast except. So
alcohol leads to cirrhosis.
Montelukast is
Say that it compensated cirrhosis lead to.
So Montelukast is a leukotriene pathway inhibitor. So yeah, we can go to the notes of leukotriene pathway inhibitors. I think drugs used to treat asthma. Yeah. The answer is in slide 20. Okay. The answer is in slide 20. Montelukast. So, okay, it's most prescribed. So it's a leukotriene pathway inhibitor. So once again, just as for the story about COX, just similarly to COX, leukotriene pathways inhibitors, it's related to eicosanoids, which is a topic in second year. So I really encourage you guys to go and read on eicosanoids, the topic of eicosanoids in second year, because it will help you relate better to what's being discussed now in third year. So Montelukast is most prescribed because it may be taken without regard to meals. It's taken once daily, others BD, by daily, I think twice daily. Does not require periodic monitoring of liver function as Zilotrin does. So we know Montelukast is a preferred leukotriene pathway inhibitor, and these are the reasons why it's preferred. It can be taken with meals or without meals, like without regards to meals. It's taken once, so it does not need to take it multiple times a day, and does not require periodic monitoring of liver function as Zolotone does. Yeah, so what was the question asking? So A, does not require periodic monitoring of liver function tests. That's true. It's a leukotriene receptor antagonist. Yes, that's true. Recommended as monotherapy for rapid reversal of bronchoconstriction in asthmatics. Okay, I don't think it's for rapid reversal. I think it's more of a slower process. Used to prevent asthma symptoms, yes, obviously, because it's in the it's topic respiratory, so under asthma. So yes, it's used to treat asthma. It's used for the prevention of asthma symptoms, yes. Food does not affect absorption, that's true. So the answer is C, because the others are all true. For number 4, true of pioglitazone. So pioglitazone is a thiazolidinedione, which is a it's a type of antidiabetic medication, specifically oral antidiabetic medication. So yeah, we can head on over there. Diabetics or Ukraine. Oral diabetes medication. So the answer is in I think slide 58. Yeah. Okay. Thiazolidinediones. They're used in type 2 diabetes as monotherapy in combination with metformin. By the way, metformin, I think, is a first line in treatment of type 2 diabetes. So yeah, that's just something I wanted to mention. So it's used in combination with metformin, sulfonylureas, or insulin. The combination with metformin has the advantage of not causing hypoglycemia. So now this combination of, this advantage of not causing hypoglycemia is called now a euglycemic effect. Yeah. So not only does it reduce the blood sugar levels to the normal, it does not cause a reduction below the normal, and that's called a euglycemic effect. So that's an advantage of the thiazolidinediones when used with metformin. Yeah. So the question was asking, true of pioglitazone. So it increases insulin resistance in tissues. No, it should cause an increase in insulin sensitivity in order to lower the blood sugar levels to normal. Yeah. Oh no. Yeah, combination with metformin has euglycemic effect. Yes, does not cause hypoglycemia. Yeah, so that's true. Usually administered daily via the intravenous route. No, it's given orally. It's called an oral antidiabetic, so it's taken orally. Yeah. I think the intravenous ones are like insulin and stuff, like therapeutic insulin. It's given intravenously. Reserved for diabetes mellitus patients with severe congestive cardiac failure. No, it's contraindicated. I think it was mentioned here. I don't know if it was mentioned. Yeah, here, thiazolidinediones, they are not used in severe congestive cardiac failure. And also, they're not used in hepatic disease or abnormal LFTs. Also, they're not used in pregnancy. So they are contraindicated in those 3 things. Severe congestive cardiac failure, hepatic disease or abnormal LFTs, and pregnancies. So when you have a problem with your heart, liver, or if you're pregnant, you cannot be given those oral antidiabetics and thiazolidinediones. Yeah. Alpha glucosidase inhibitor, it's not. It's a thiazolidinedione, not an alpha glucosidase inhibitors. The alpha glucosidase inhibitors are these ones: acarbose, miglitol, and foglibose. Okay. Number 5. True of irinotecan except. Okay. So irinotecan is a topoisomerase 1 inhibitor. It's a drug used to treat cancer. It's an anti-cancer drug. So here I did not find this. Okay, I did not find the answer in the notes, but just that choice A is true. Yeah, because the other choices, I think they were conflicting. So for here, I just settled for A. Diarrhea that occurs 7 days after administration is treated with atropine, because atropine is an anticholinomimetic. Atropine is anticholinergic. So it's used to treat the, like it causes anticholinergic effects on the body that, for therapeutics. So yes, definitely I can buy that atropine can treat diarrhea. Yeah, because it can reduce gastric bowel movements and such, reducing chances of diarrhea. Yeah, so A makes sense, so I think it's true. So number 6, which one is not an indication of piperacillin combined with tazobactam? So this is second year work. Piperacillin combined with tazobactam is a drug called tazocin. Yeah, and you can get this answer in topic for penicillin, which is in second year. I think I have the second year drive here. Okay, so the answer is on slide 75. So let me just keep on over there. Okay, the question is asking, which is not an indication of piperacillin combined with tazobactam. So when combined with a beta-lactamase inhibitor, such as tazobactam, piperacillin tazobactam, which is called tazocin now, it has the broadest antibacterial spectrum of the penicillins. So it can treat Staph aureus, H. influenza, P. fragilis, and most E. coli and Klebsiella. So, okay. Endocarditis, okay. It can treat most infections. The notes are saying it has the broadest antibacterial spectrum of the penicillins. So, endocarditis prophylaxis before dental procedures in patients with heart disease. So that was for amoxicillin. That's the reason why choice A was wrong. So we had to go back. I had to go back and search for what the notes for amoxicillin was saying. But the rest were true. Okay. Serious infection by gram-negative organisms, yes, definitely. Hospital-acquired infections, yeah, because this piperacillin tazobactam combination is a very, very, like effective drug against bacteria. So most of these common infections are treated with it. Mixed intra-abdominal infections, yes, and infections in neutropenic patients. Yeah. So for the notes for amoxicillin, they're in slide 63. Here, amoxicillin half-life is 80 minutes, so relatively short half-life compared to most drugs. Actually, no, it's very short. 80 minutes is really short. So I think like the drug should be given like very continuously, like many times a day or something, multiple times a day. 20% protein bound. This means that 80% is not protein bound. So 80% is just traveling freely in the blood, therefore diffusing easily into the tissues. Yeah. So there's no need of a high dose because there's no need of a largely high dose because little of the drug is protein bound. It's excreted through kidneys mainly as active drug. And adjust the dose in renal failure. Of course, if there's renal failure, you have to adjust the dose because kidneys are ones that excrete the drug. So amoxicillin, antimicrobial activity is similar to ampicillin. It is less effective than ampicillin for shigellosis. Okay. Amoxicillin is the most active of all the oral beta-lactam antibiotics against both penicillin-susceptible and penicillin non-susceptible Streptococcus pneumoniae. So I think this means that whatever strep pneumoniae penicillin can take on, amoxicillin can also take on. To overcome pneumococcal resistance to penicillin, increase in dose of oral amoxicillin. In short, it's saying if you're giving a patient penicillin and there's pneumococcal resistant, add amoxicillin, because amoxicillin can give the a boost to to like fight the bacteria, fight off the bacteria. Yeah, so yeah, this was the keynote wanted to take home. It's amoxicillin is used in prophylaxis of endocarditis before dental procedures in patients with that disease. So those are some. So not only should we take note of that, but also other therapeutic indications for aminopenicillins. So amoxicillin is also used in respiratory tract infections. So sinusitis, maybe otitis media, and pneumonia. I think these respiratory tract infections mostly handled amoxicillin. UTIs as well. Meningitis caused by Listeria monocytogenes. Yeah, ampicillin. Same as I think this is the same as ampicillin. Yeah, and prophylaxis of endocarditis before dental procedures in patients with heart disease. So yeah, so this is an example of, if you don't know, you don't know in the exam room. So this is if you don't know, if you aren't aware of this about amoxicillin, it's hard for you like to tackle that question. So just take note of this as a key thing to remember about amoxicillin. It's indicated in respiratory tract infections, UTIs, meningitis caused by Listeria monocytogenes, and prophylaxis of endocarditis before dental procedures in patients with heart disease. Especially this, because it's a very specific situation. Yeah. I think we've tackled about number 6 enough. So number 7, true about factors that affect pediatric pharmacology except. So this is a second year topic and pediatric pharmacology. So you can head on over there. Let me just close some of these. Or maybe I can just open another pharmacology. Okay. So we can go through each choice on a case-by-case basis. So for choice A, the answer is in slide 17 over here. Okay, this choice A is saying skin surface area to body weight is lower than in adults. Like children's or the pediatric skin surface area to body weight is lower than in adults. So it's the skin surface area is actually higher. The skin surface area to body weight is 3 times greater than an adult. So yeah, I think the smaller you are, the greater the surface area to body weight ratio. Yeah. Because of this, 3 times the amount of drugs is absorbed for an identical percutaneous dose in an infant than an adult, because the surface area to body weight is larger. So these dermatological drugs are absorbed more of the larger concentration of the dermatological drugs are absorbed. Yeah. So true about true about factors that affects except. So A is wrong, definitely, because we've just cancelled it out. But you can look at the other choices. So choice B, plasma protein levels are low. So the answer to that is in slide 22. Drug distribution. Okay. Yes, the choice is saying plasma protein levels are low in the pediatrics. So here clearly says there's low plasma proteins. They reach adult values by 10 to 12 months of age. Yeah. So there's low albumin, low alpha-1 acid glycoprotein. Therefore, binding affinity is also low. Yeah. So drugs are less bound to those transport proteins. Yeah. So they may be associated with more free drug concentrations and adverse effects initially. Yeah. If free drug concentration is increased, then drug elimination also increases. Yeah. So choice C, the blood-brain barrier is more permeable in neonates. So the answer to that is in slide 26. So slide 26 says blood-brain barrier is immature, it's more permeable in childhood. You're saying blood-brain barrier is more permeable in neonates. Yeah, so it's more permeable in childhood. Yeah, I think that's clear. Choice D, activity of liver enzyme is reduced. So we can get that in slide 27. Drug metabolism. Most drugs are metabolized in the liver. The activity of CYP450 mixed function oxidases and the conjugating enzymes are 50 to 70% of adult values in early neonatal life. So they are 50 to 70% of the adults. And in short, they are less than 100% of the adult values, meaning they are less than in the adult values. So yes, the activity of liver enzymes is reduced. That's true. Choice E, renal function is decreased in neonates. You can get that in slide 32. Drug excretion occurs mainly through the kidneys. The glomerular filtration rate is much lower in newborns than older infants. So GFR compared to adult values, newborn is 30 to 40% of the adult value, 3 weeks old, 50 to 60%, and 6 to 12 months is 100%. So basically, to saying, renal function is decreased in neonates. I think a neonate is a child less than 1 year. I think it's a neonate. No, I think even less than 1 month, not even 1 year. Yeah. So yeah, an infant, a neonate is a child less than a month old. So yes, so from 3 weeks going behind, there are fractions of the GFR values in an adult. So yes, renal function is reduced in neonates because of the GFR being percentages of the adult. So go on to number 8. True of imatinib except. So imatinib is it's an anti-cancer drug. It's a tyrosine kinase inhibitor. Yes. But I did not manage to find notes in regards to this question that could give us sufficient information like to get an answer. But okay, if notes are not giving, okay, if the answer is not available in the notes directly, you can always Google or use other, like sources of information or study material that will give you an answer. So from this, you can tell, okay, the obvious eliminator. Okay, the first thing to eliminate here is choice B, because yes, imatinib is a tyrosine kinase receptor. The ones drugs ending with, I think, tinib, they are tyrosine kinase receptors. tyrosine kinase inhibitor, sorry. Yes, it's given orally, and also it's excreted in the feces. So there's causes fluid retention. Yes, that's true. So the answer that was wrong is this. The false statement is there's cross-resistance due to mutations between imatinib and bromatinib. So yeah, I don't know if cross-resistance works that way. So moving on to number 9. Amoxicillin is ineffective against, I think we mentioned this. I think we just went through this when we were talking about the penicillins just a moment ago. So strep pneumoniae, yes, is treated. In fact, we said amoxicillin can now, can we say, it can support other, penicillins in the treatment of streptococcus, I think. Yeah. Haemophilus influenza, yes. H. influenza was there. E. coli, H. pylori, Klebsiella, yeah, they were there. I don't think amoxicillin is effective against methicillin-resistant Staph aureus. Yeah. So number 10, I think we can do like we can finish this page, then we can call it a night. Yeah. So true of paracetamol. Okay. Does not inhibit COX, cyclooxygenase. So yes, we said it inhibits COX in the hypothalamus, if you guys remember. It's an indole acetic acid. No, it's an indomethacin. I think you can just go to that. I think we can just go to that slide. We go directly to that slide. Okay, so paracetamol does not inhibit cyclooxygenase. It does. It mimics NSAIDs in that way by inhibiting COX. In fact, it's here. It inhibits COX in environments that are low in peroxide, such as hypothalamus. Okay. It's an indolacetic acid, no. Indolacetic acids examples are, they're down here. Indolacetic acids are indomethacin and sulindac. Paracetamol is an paraminophenol derivative. Yeah, so no antidote for hepatotoxicity. It actually does. It's the N-acetyl. Just called N-acetyl what? Yeah, N-acetyl. Not that. Verse effects. N-acetylcysteine. Yeah, N-acetylcysteine is the antidote for paracetamol hepatotoxicity, together with oral methionine. Yeah. Causes respiratory alkalosis. It doesn't. It causes renal tubular acidosis. So paracetamol causes renal tubular acidosis, together with pancytopenia, diarrhea, and hypoglycemic coma, and skin rashes. Yeah. Alternative to aspirin in patients with peptic ulcers. Yeah, this is true. It's directly from the notes. It's here. Here. Paracetamol is an alternative to aspirin in patients with peptic ulcers. Because remember, paracetamol has, I think, it has less of like gastric, less of a COX inhibitory effect on the gastric mucosa than aspirin. So it causes less damage. I think it causes less damage in peptic ulcers or PUD cases. It's also an alternative to aspirin in patients where prolonged bleeding time is undesired and where there's aspirin hypersensitivity and children with a febrile illness. Yeah. So, yeah. So the answer is E. Which is number 11, premedication is used before intravenous infusion with. Okay, I was not able to find notes that would support the answer to this question, but okay, if the answer is not found in the notes, you can always use other material like Zoom or any other material you may have to get the answer. Yeah. So the answer is E. So most monoclonal antibodies are given with premedication, such as rituximab. So premedication are like drugs given before certain drugs are given before the administration of other drugs, like to stabilize the patient because of the adverse effects of the latter drug. Okay, so can use antihistamines, antipyretics or NSAIDs such as acetaminophen or glucocorticoids, like to counteract the effects of rituximab. We use these premedications in preparation for the rituximab, so that when you use the rituximab and it has some like side effects and stuff, these drugs counteract those effects. Okay. Number 12 is the last question for tonight. Identify the second messenger. So the answer is glycerol. These are second year notes. So we can just go there a bit. This topic called G proteins and second messengers. So the answer is in slide 4. Yeah. Many drugs act by increasing the intracellular concentrations of second messengers, such as cyclic adenosine monophosphate, that's the cyclic AMP, calcium ions, phosphorinositide products, these are diacylglycerol and inositol triphosphate. So yeah, cyclic AMP, calcium ions, the DAG, IP3, and cyclic GMP. So yeah, those are examples of second messengers. So I think that's enough for today. Let me stop sharing. Okay, thanks for all those who joined. Thanks for listening. Thanks for contributing. Okay, I've noticed there's someone who's raised their hand. I don't know if
Yes.
I don't know if it was to ask a question because I did not notice the hand was raised until right now.
No, it's right now. I've just raised it right now.
Okay.
It's about rituximab, the number 10 question.
Yeah.
The answer is actually in biological DMAT.
Where exactly?
When they're talking about the biological DMATs, so when you're talking about the rheumatoid arthritis drugs, so now under it they said like it's actually in the class notes. I don't know.
Okay. Let me stop recording.